Hey guys, Woodruff here. Now let's talk about what happens as things start to get worse. So the last video was a part of my it's part of my long lecture over cardiovascular disorders, and we were talking about coronary artery disease, which we talked about as it's kind of like stuff is brewing. There's signs of plaques. There is kind of narrowing of the arteries in the coronary arteries, which supply the heart with oxygen, starting to happen. But now we're going to get into what's known as CSA or chronic stable angina. When you get into your future semesters, and again, I'm talking just speaking for my school. By the way, I'm playing with a fidget toy, so if you hear weird like noises that sound like I'm farting, it's just me playing with my fidget toy. In at least at my school, we don't cover MI in med surg, that we talk about that in our complex course. So we're really just going to focus on this, on what is angina, what does it look like, how do I know it's getting better or worse, and how are we going to treat it? And we're talking about chronic stable angina. So to understand what the difference is between coronary artery disease and chronic stable angina, and then what happens next, we want to get some good visuals. So this is a picture kind of what's going on with plaques as things progress. And we have here, with what do you call it? With CAD, remember there's no symptoms. They just have plaques, they just have the narrowing, but they're not actually having any sort of angina, pain, etc. So once we get to chronic stable angina, we're starting to have an issue where it's just like when patients with PAD or peripheral artery disease begin to have intermittent claudication and things like that. It's gotten to the point that now there is, actual, such a low amount of flow or oxygenation that alternative metabolism begins, and then some of the chemicals from that lead to this pain, this ischemic pain. It's a pain from lack of oxygen. It's not a pain like, oh, I fell down and hit my arm. It's a pain from lack of oxygen. So yes, so let's get in here. So let me see. So I was gonna say that. So but the thing that's different about stable angina compared to other types of angina and heart attack and stuff that you're going to learn about later is that the EKG is normal. The cardiac enzymes and things like that are normal. There's no elevation in them. There's no actual cell death. There's no actual tissue damage. And it's very predictable. So compared to others, like we know there's something that comes right before it, there's something that precipitates it, which we'll talk about the factors and things that precipitate angina. And we also know, still me with the fidget toy, I promise. I feel like I should stop explaining myself, because even if I was farting, is it any of your business? But it's all good. Anyway, with stable angina, it's very predictable. We know it's when it's going to happen. We know what's going to make it better. It's not as dangerous. Whereas with the others, there's actual blockages happening. It's more unpredictable, or there's actual damage to the heart. So let's get more into this. Like I mentioned, chronic stable angina, or CSA, it develops from CAD. And effectively what it is we call again, the plaque buildup and the narrowing gets to a point where when I am doing certain activities like exercising, or when I am stressed out, things like that, I get to the point where I actually start to have symptoms associated with my narrowing and the plaque buildup. Or it's getting more severe. And it really is all about a supply and demand issue, that I either have a higher demand for oxygen that exceeds the amount of supply. I can start to get to the point when I have angina. I can start to get to the point where it's possible for cell death to occur. Now, remember, chronic stable angina, there's no actual cell death happening. But this is what can lead to much more serious problems, especially if it's left untreated. So again, angina is chest pain, and it's pain specifically related to lack of oxygen. Ways that you might want to look at chronic stable angina is it's pain that is intermittent over a long period of time. And again, like I said, it usually has a trigger. Most commonly, it's like physical exertion, going and playing golf, going for a walk. We're going to talk about a lot of different things. There's a lot of triggers for, but physical exertion, or other physical emotional stress, anything that can increase my heart rate or my blood pressure can be a trigger for this. But overall, we want to look at the things that are, we want to look at that supply demand chain as well and really see like, okay, what is increasing my demand for oxygen or decreasing my supply? Because this is a lot of, how we help to manage chronic stable anginas. We want to avoid things that are going to increase my demand for oxygen or things that are going to decrease my supply. So, talking about a few of those things, things that are going to increase the demand for O2. When I say increased demand, I mean that my body's going to say, hey, because of this, I need more oxygen. It's saying, I need more, I need more. And so think of things that are going to, stress you out or work things hard. So it could be things like simple as physical exertion, high blood pressure, anxiety. You're taking a nursing school exam. It's over cardiac and you love it. You're just so excited because you just want to do well because you think you want a future in cardiac. So I promise I'll stop creating stories. But in my head, this is what y'all are thinking. You're like, I'm just so anxious and nervous because I want to do well on cardiac because this is my future. Anyway, if your heart rhythm is super fast, like your heart's racing, or if it's abnormal, not getting good perfusion, other things that would increase demand would even be things like infection, can do it as well because infection, inflammation, anytime where your body has to work harder, be fighting something, you're going to need more oxygen because oxygen's needed to help with all of those things. Then there's also things that can decrease my supply. I could have stuff on both ends. I could have an increased demand and decreased supply, but sometimes I only have one or the other. Things like abnormal heart rhythms, again, bleeding or anemia or having low blood volume. Because again, if I don't have the, like think of your blood cells and oxygen like an Amazon store. If I don't have the people to deliver the oxygen, it doesn't matter how much oxygen I have if I don't have the delivery trucks. But also could have that I have less oxygen supply, like things like respiratory disorders like asthma, COPD, pneumonia, things like that. So like I said, there's a lot of things that can precipitate or bring on angina or chest pain. So we talked about physical exertion, anything that can increase your heart rate. And you want to think about this, that when your heart is racing faster, there's less time for your heart to rest. Like there's less, ability for your heart to get more oxygen out because it's just like, it's going really fast. Like normal, there's this like really great, ability to like spit it out. Like you're able to think of like, well, this may be not the best analogy, but in my head it seems to make sense, but my head's a strange place. Is that like imagine like you're getting like you're all your saliva together to do a really good spit. Like if you don't take the time to do good spit, you're just going to get a little bit out. It's the same thing here. Probably a much better analogy is that what do you call it, if you were squeezing a water bottle and if you're squeezing it like a nice slow controlled, not slow, but regular controlled contraction, you can get a good amount out. But if I'm doing like this, I don't have as much good squeeze. And it's also like really what it comes down to in the heart, and we'll talk about this more with heart failure, but when my heart's beating really fast, I don't have time to fill, and if I'm not filling, I'm not getting as much out. But it also stresses my body out and again increases that need for oxygen, and can also decrease my supply because I'm not having that filling time. Intense emotions like the moment you fall in love with cardiac can definitely increase your sympathetic nervous system reaction and lead you to having that anginal pain. Temperature extremes, if you're super cold, you can have constriction or narrow vessels. We're on the opposite end. If things, if things get really, what do you call it? If you have moments where you're getting very vasodilated, and there's a lot of things that can cause vasodilation from heat, like getting in a hot tub, hot bath, living in Texas, things like that, things get very dilated. And this is going to affect, the delivery of my oxygen, and also can increase the demand as well. But the constriction can make things even worse, because even despite, we call it what's happening in the vessels, you want to think about that. If they're dilated, they don't have enough squeeze to get oxygen in blood back where it needs to be, and if they're constricted, it makes more narrow pathway. Heavy meals can do it because we have decreased blood flow to our coronary arteries. And then we also have some, what do you call it? Oh, that was a really loud one. Sorry. It's a little piggy, is making a lot of noise. So I found this in my son's room like 10 minutes ago, so don't mind me. And I forgot that I had it, and so just wanted to play with it. It helps for these long days, recording videos. Not that I don't love y'all. I do this for you, but if you, if you knew the honest truth is that, if I, I make these videos because I know they're helpful and I will continue to make them, but I would much rather be teaching in front of a class than sitting in front of a computer. So, I will continue to do these, but sometimes I need a little something to keep me going. But anyway, so heavy meals can also do, cause angina or make things more difficult in the sense that we want to think about like diversion of blood. So like heavy meals, like my heart, kind of think of it that it's sitting there and saying, who needs the blood right now? Like who needs it the most? So if it's like there's some issue going on somewhere in the body, it's going to divert to there. We talked in another section about when like with PAD, how at night cardiac output goes down and the blood's like, hey, who needs the most blood right now? Oh, I'm digesting. I'm going to send it to the GI system. So the same thing's happening here is that when there's a really heavy meal, like the blood flow gets pushed towards the GI system because the body's like, whoa, 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 we've got a real big problem here. We got a large meal we need to digest. I need a little extra flow over here. So yeah, just think of it kind of like hospitals that maybe had extreme shortages of nurses when they needed extra help and they're like, hey, we need more guys over here, same kind of thing. Tobacco use, we've talked about this. Vasoconstriction causes damage to the wall, so it can lead to a lot of different factors, but it's that constriction specifically that can lead to more angina. The supply demands is off. We talked about sexual activity. The increased heart rate, increased blood pressure can lead to narrowing and also an increased oxygen need or demand. And then anything that's a stimulant like cocaines and amphetamines, sadly, they are never good for your cardiovascular system. So, when you're thinking about CSA, like I said, we're not going to cover any of the other types of angina. There's also other types like Prinzmentals and all the stuff. We don't get into all the different types of angina. We're really just focused on chronic stable because we're on med-surg level. What are you going to see on med-surg level? Once you start getting into the unstable angina, heart attacks, acute coronary syndrome, we're getting into the ICU territory. But if you're going to learn about chronic stable angina, you need to know what's okay and what's a sign that it's getting worse. So even though we're not going to, test you over MI and stuff like that, you need to know what kind of comes next after chronic stable angina when you would need to call the doctor. So chronic stable angina, again, it's that intermittent pain. It usually doesn't last more than a few minutes, and it always starts with a precipitating factor. And this is why that pain assessment is going to be one of your priority assessments. We're going to talk about that a lot here soon in a minute. But the other thing that's really characteristic of chronic stable angina is that it's going to get better if the patient is resting or if they take nitroglycerin. So in other words, effectively with chronic stable angina, we know like we can like pinpoint like, hey, I did this and then the chest pain started. And then also we can really closely look at, okay, now like the chest pain started, I sat down, I felt better. I took a nitroglycerin, I felt better. Like it's easy to identify what started it, and it's also easy to identify how to stop it. Once we start having more problems, like, or there's other stuff going on, or we're like, we're getting into unstable territory, what's going to happen is that their pain is going to be increased. It's going to be usually described as worse or different than their chronic stable angina pain. It's going to start happening at rest. Like they're not doing anything. There's nothing we could pinpoint that could have caused them to have an increased demand or decreased supply, or they're minimally going to have to exert themselves, like just maybe like minor change of positions and the chest pain starts. It's also going to last for longer periods of time, and it's not going to be relieved by rest or nitroglycerin. It's starting to get a lot more unpredictable. So really what you want to look at is chronic stable angina. I can predict this thing. I can see the start and the end. Unstable, I don't know why it's starting, how it's starting, when it's going to start, and I don't know how long it's going to last either, or what's going to make it better. That's where we kind of start to differentiate. So these are the cues you would look for as a nurse to see that things are getting worse or not going well. So, patient complains of pain, and we're going to talk in depth about the pain, but it's related to ischemia. So, they need more oxygen. This is a big oxygenation issue. Again, it's not something that a Tylenol can fix. Patients can also complain of things like shortness of breath or fatigue, and we'll talk about more symptoms on the next slide. But the kind of questions that you want to ask, you want to be very specific with your questions because it's not just saying, hey, what's your pain on a scale of 0 to 10? We really need to know because remember here, we're trying to look for differences that would identify that this patient is getting better or worse. So we want to know, was there a precipitating event? Did something happen right before? So we want to know like what happened right before, what were they doing before the pain started? How would they describe it? Is it sharp? Is it dull? Squeezing heavy? The region, where is it? Is it in one place or is it radiating anywhere? And like, for example, people with CSA might have radiating arm pain or radiating jaw pain. And this is just my pillow in the background. Don't mind it. I'm just chillaxing over here. I'm gonna have to stop doing that because it's gonna distract me either way. I'm gonna put down the pig. Severity of the pain. So we do ask about the how bad it is, and then we also want to ask about timing. And so we want to see about like, when did it start? Like how long has it lasted? Has it changed at all? And is it something that they've experienced before? We're trying to look for what's different or if it's characteristics of what they've experienced so far. And so these are really key assessments, and I'll tell you why they're key is that when a patient comes in and they're having chest pain, we really want to map or, keep an eye on that pain because that pain is linked usually to a specific blockage in a specific artery. Now, if we go in and fix that, let's say that we go in and we fix whatever it is, maybe we put a stent in, something like that, because there is some sort of blockage. Then what we're going to, have to keep in mind is if the patient starts having chest pain again, I need to know, is it the same as what it was before? Like, I'm trying to pretty much, like figure out what is the issue. If it's the same as what when they first came in, maybe there's a problem with that stent or that intervention that was done. Maybe something went wrong. If it's a new or different pain, maybe there's a problem in a different coronary artery. But if essentially, I want to know what was typical of them so that if I had a patient, especially like let's say I had a patient that came in and they were having like shooting arm pain, shortness of breath, or something like that. And then they start having that again. That should cue me as the nurse, like, hey, they might be having a continued problem. It's the same thing that brought them in. And this happens often, so it's definitely something you want to keep in mind is really understanding your patient's pain when it comes to chest pain and what it's like. What happened right before? Did they just eat? Could it be heartburn? Like what else could be going on? We also want to look for perfusion because if I have possible ischemic pain, I want to check their vital signs, see if they're stable with it. And then also maybe look for signs of end tissue perfusion in my peripheral extremities and my organs, like my kidneys, things like that too. So, like I said, there's some typical places that patients have chest pain. Usually we think of like the hallmark or the, the textbook or TV version of a heart attack is, hand on the chest, an elephant sitting on my chest. And, that's kind of the really typical, symptoms that someone might have with chest pain. But there are other places people can have pain, as you can see here, that's in the neck, it's in the jaw, in the shoulder, could be in the back as well. And there's also people that have atypical. So that's why I actually created this little fun activity. And all these activities, even if you're sitting there like, I don't really need to know this. The reason I have these inserted in here is not always that this information, this slide is going to be on the exam, because I don't know. A lot of times when I make these, I don't even know what's on the exam. But it's really looking at practicing questions like these next generation questions. So you could have questions like this. They might be worded a little differently, but it's the same concept that we're trying to see if you can put things into categories or, kind of see those differences. Now, this is more of a knowledge one, but a lot of times there can be application or higher level ones too. And you can kind of take this and create it. Like you could create your own, like say, okay, a patient came in with blah 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 pain. Which of these would warrant the nurse mark and categorize them? Is it warrant the nurse calling the doctor? It does not warrant, or it's not applicable, or something like that. There's lots of ways to make these your own, especially if you struggle with SATA or other things. These are it's kind of almost like a drag and drop or it could be like a fill in the blank. It can definitely help to practice. Students generally struggle when there's a lot of data because one, they either start to try to categorize in their head like, hey, there has to be at least this many, or they start second guessing themselves versus looking at each one. It's a separate, question, true or false, as you go down. So the first one, chest pain after, what we're answering is we want to know if all of these are either typical signs of a heart attack, atypical signs, like maybe not the most common, but things that people can get, or not applicable, nothing to do with like how people would present with ischemia to their heart. So first one is chest pain after climbing a flight of stairs. Well, that sounds really typical because there's like a activity or precipitating factor that climbs the stairs and then the chest pain comes. That sounds very typical, and chest pain is a very common sign of heart ischemia or chest pain. So, shortness of breath. So this is actually what we would consider to be a atypical. So women come in with more atypical symptoms. Usually women and diabetics have the atypical symptoms. And so a lot of women come in with shortness of breath. And there's another one on here that's very typical for women that is also known as a atypical symptom. So let me not say typical for women because I'm going to confuse y'all. But shortness of breath is an atypical symptom, more likely in women. There's also leg pain with walking. So I got to sit here, I got to look back at the question because I'm like, okay, well, that sounds like PAD or intermittent claudication. But it says, which is a typical sign of heart ischemia. If I'm having a ischemia in my heart, should my legs be having pain with walking like that? They're just not related. So I'm going to say this one is not applicable. Nausea, vomiting. So this is another one that is actually atypical, but that you'll find more commonly in women. So the shortness of breath and nausea, vomiting, or other GI symptoms, those are really common in women, and they kind of present with these atypical signs and symptoms, which is a lot of times, the new textbook talks about this, about women are actually like increasing their risk for more complications and problems with cardiovascular disease, just because they don't, oh, sorry, the yards getting on, they come out of nowhere. They come in with the symptoms that you wouldn't expect. So like, if I had a patient that came in, they're short of breath, having nausea, vomiting, in my nurse brain, I'm thinking they have an infection, something else. I'm not like, ooh, heart attack, so that's why you definitely want to think about these atypical symptoms. There's also jaw pain, which is actually fairly common. In the past, it's usually been seen as an atypical symptom, but it's become more common with time. Chest pain that gets better with rest. This is definitely well, I should say, that's a good question. I wrote this myself, but I did say what's a typical sign of heart ischemia. And yes, as a whole, if I'm having chest pain, it's usually a sign that there is some sort of oxygenation issue. But if it gets better with rest, that's a good question. But more so, I think what I'm focused on here is if a patient came in with this, really what I think I was trying to get you to ask, if a patient came in with this, would I think they could be having heart ischemia, or I'm worried about like heart blockages? And if someone has chest pain that gets better with rest, yes, even if it gets better, I'm still worried about the possibility that it could get worse and they could have heart ischemia. And yes, I did grab it again. I lasted about 2 minutes without it. So doing a pretty good job. So I'm going to say chest pain that gets better with rest is more typical. No symptoms. So you might say, this is not applicable, but it's actually atypical. So just like I said, women have different responses or different types of pain. Diabetics can also have different pain. Remember diabetic neuropathy where they can't feel their feet. They also can have a painless MI. So sometimes they can have no symptoms. Then we have blood pressure. Oh, so let me back up. Is that the no symptoms too? What we're going to be concerned about is that this is happening. What do you call it? This, like, there's nothing precipitating or any way to know that a patient is having this. So it can be very dangerous or deadly. So that's why keeping up with regular health screens and stuff like that is so important for diabetic patients. Then we have blood pressure 160/99. And so this has a high blood pressure, and it's definitely, I don't like it. It doesn't look good. But I have to, that's not what the question's asking me. It's asking me is when it comes to this, sign or symptom, if a patient came in, if they had this blood pressure, would I be like, ooh, heart ischemia? And the honest truth is that it's really not applicable. It's not a common symptom. We can't look at blood pressure and definitively say someone is having a heart attack or not. It actually could go either way, or it could be unrelated, unchanged. Last but not least, we have shooting left arm pain. And this is actually a very typical sign of heart ischemia. So definitely want to keep that in mind, that something to look for. So as a whole, we have typical signs like chest pain, either after activity or that gets better with rest. We have jaw pain, and shooting left arm pain is pretty typical signs. Atypical signs, especially for women, are going to be, or atypical signs that are going to see more commonly in women, shortness of breath and nausea, vomiting. Then we have no symptoms for diabetics. And yeah, I think that sums it up. Hopefully that helped. But just know there's a variety of symptoms here. So how do we know that a patient with chronic stable angina is getting better? Well, we know they're getting better if they're having decreased or less frequent pain. With the angina, of course, we our overall goal would be that they, like, yes, we want them to have less pain. We want them to have less pain, because the pain they're feeling, yes, I don't want my patients to ever be in pain, but the pain they're feeling is related to a lack of oxygen. So I really want them to keep their beautiful, beautiful heart oxygenated. But that pain can be a good indicator of how they're doing. Now, it's not to say that you have to have pain to have damage to your heart, but definitely we don't want them to have frequent pain, things like that, because that's saying frequent times their heart is without oxygen. Their signs that they're getting better is going to be if their pain gets better with those regular treatments like rest and nitroglycerin, as it should. Maybe also improved activity tolerance. If we really start to get at some of the risk factors and stuff for CAD, we can get to a point with people with CSA where they can actually tolerate activity better. In other words, that when they are doing something that maybe in the past would have caused them to have chest pain, stuff like that, now we may start to see that they are having, they might tell you like, hey, wow, like I can do this activity so much easier. Hey, I'm not so tired anymore. Hey, I didn't get out of breath. Hey, I didn't have any chest pain with this. And then of course, signs that they're getting worse are going to be new or different chest pain, pain that does not get rest with it does not get rest. Pain that never rests. Pain that does not get better with rest and nitro. So we're seeing that sign of that move from chronic stable into unstable. Having pain at rest. Any signs of decreased oxygenation, or their activity tolerance even worse. If they get to the point where, like before, it was like, hey, it was just really hard to get up and go to the bathroom, and now if it's like I can't even turn over in bed, things are getting a lot worse. So a lot of these labs, I don't go in depth in them on these slides. I went in depth on these labs and the diagnostics when we went over coronary artery disease. So if you're looking more on these labs and diagnostics, that would be a better place for them, for learning about them. But effectively, we're going to look, how bad is it? Is it getting to the point where there actually is heart damage? Now, generally, chronic stable angina, there should be no increase in these, but it can definitely happen with time. And without regular monitoring. This is a plaque problem. So just like with PAD, we need to keep an eye on how the plaque in my arteries is doing. Then we also want to look at electrolytes, because we want to look at everything that could affect my ability to perfuse or to get flow. I'm gonna put it like flow in my brain. We're not at stroke yet, flow, because apparently my brain is not flowing today. But we want to look at anything that could affect flow to my beautiful, beautiful heart. And if there's electrical issues and other things, this can affect supply demands, like we talked about, when it comes to getting good flow to my heart. So we might check electrolyte levels and try to alter or change things that could improve the amount of flow that I'm getting to my heart. So in other words, I don't want them to be having a issue with what do you call it, electricity, because the electricity issues could then lead them to having a problem, making it even harder on the heart. In other words, really think of CAD, and we're going to talk about this a lot with heart failure, that with CAD, I am trying to prevent their heart from getting stressed out at all. I don't want anything that's going to stress it out. And one thing that's going to stress it out for sure is fluid and electrolyte imbalances. And so we really want to stay away from the electrolyte imbalances, especially because it can lead to dysrhythmias. Diagnostic testing is mostly the same. Remember, there's two reasons we look at an EKG. First, I want to see, okay, yeah, I had to do all the labs. For some reason, I was having a brain fart. And so we want to look at an EKG for two reasons. One, to maybe look for dysrhythmias. Two, to look for that ST elevation that we talked about, or other ST changes that could tell me that there's a ischemia problem going on in my heart. Specifically what we call a STEMI, or it can also show a non-STEMI or signs of a previous heart attack. We also want to get stress testing, and I talked about in the other PowerPoint how with stress testing, effectively what it is. It's not going to nursing school, even though, like, I joked with my students, and I was like, that would be a great stress test. Put them in front of a nursing school exam, and then let their heart start to race. Oh, so sorry for yours today. Pretty much what you have going on here with stress testing is that we're either putting them on a treadmill, or we are giving them a medication that's going to cause them to get more stressed out. When their heart is more stressed out, then we're seeing how does it handle things, or how does it respond under stress. If they're starting to show signs of, like, when they're exercising and doing other things, whether it's the medication or the exercise stress test, if they start to have a severe change in their vital signs, severe symptoms, things like that, then we're going to be concerned that there's ischemia going on. Effectively, we're testing, is the narrowing and the plaque buildup enough where they're actually starting to have symptoms, and things like that with that, when there's strenuous activity, etc. We talked about that you can do the cardiac cath or coronary angiography, which is where we go in and look inside. And then we also talked about using the echocardiogram, which, effectively we're trying to look at all different aspects of the heart when we are approaching, we're trying to, like, evaluate for damage or possible problems related to the heart damage. And I brought up before that you want to consider that if I'm having trouble getting flow to my heart, all the functions of my heart can stop working. So what are the functions of my heart? It's got an electrical system, so my electrical system can get messed up, and then it also has a mechanical system or a pump, that can get messed up too. So really with the echo, I'm trying to see how is my heart pumping now with this narrowing of my coronary arteries. And then the only other one I'm adding that was not under CAD, which it's possible we could do it for CAD too, but more likely under this, is to look at the size of my heart. So this also helps to look for complications, or helps to look at how my body is doing when it comes to heart function. Because one of the things, oh, you're so sorry, I'm not using so yawny today. I blame the heating pad that's on my back is making me sleepy. But we call also, my toddlers get me up from early, or I'm gonna have to stop calling him a toddler because he's really a young adult, as he refers to himself, but he's kept me up since early this morning. So anyway, but yeah, the chest x-ray, what I would see on that is maybe an enlarged heart, or signs like, it could be signs of heart failure, things like that too. And so, we're really going to be looking for the size and the structure of the heart, or anything else that could be abnormal physically wise as a result. It also could help us to see if there's any other precipitating factors like pneumonia or lung disease that could affect my ability to get good flow, like the whole supply demand thing. All right, so medically, we do a lot of the same stuff for CSA that we do for, yes, I was saying it right. We do a lot of the same stuff for CSA that we do to help with CAD. So we do medications to decrease plaques, which are our cholesterol meds. We do medications also to decrease clogging, which are remember, our AC, the anti-clogs, are going to be aspirin and clopidogrel. And then medications to restore flow. So this is the one we're adding in. We're adding in nitrates. So I'm not going over anti-cholesterol meds or antiplatelets again, but they're in the vascular ones, and they're in this the last one I did, the CAD one. So you're welcome to review those there. We are going to go over nitrates because this is very specific. So in the past, I'm just trying to prevent problems. I'm trying to prevent plaques. I'm trying to prevent more clogging. But now I actually have sometimes where my heart's getting to the point where I'm having pain. I'm getting to the point where it's getting really closed off. So I can't just sit around and just say, like, I'm going to pray that my plaques get lower. I'm at the point where I might be even sometimes it's considered like an emergency where I need to open up and restore blood flow right away. And so what we use is vasodilators called nitroglycerin, or there's other nitrates too. So we'll talk more about those. And then just like for all the other cardiac diseases we've talked about so far, we want to manage other problems like high blood pressure, problems like diabetes. We really want to get those well controlled because high blood pressure can lead to constriction of my arteries, and diabetes can lead to breakdown of the blood vessels, which can lead to, a lot of serious issues, plaque formation, things like that. And then we never just do med management. We always want to look at lifestyle too. So smoking, of course, is always a big no bueno. We also want them to change their diet. We do a heart healthy diet, which will, we've talked about a little bit, but, it's a lot of the, foods and I was going to say fruits and vegetables. Yes, fruits and vegetables, more fiber, less red meat, low sodium, that kind of diet. And then exercise is good especially for your heart health. So before we get into talking about nitroglycerin, let's teach a little bit about it. I was trying to say nurse and teach at the same time, and I don't know why my brain works this way, and I look at two words and somehow my brain puts them together. A nurse is teaching a client who is taking a nitroglycerin for their chronic stable angina. Which statements by the client indicate that further education is needed? Select all that apply. So we're looking for what is right or what is wrong. We are looking for what is wrong, and it's a select all that apply. So the first one is, I will stop taking nitroglycerin if I experience flushing. So with nitroglycerin, they can experience flushing, but this seems like a medication. If it helps open my coronary arteries and restore perfusion, it probably seems like a medicine I would not stop suddenly. And I feel like flushing is expected. It's supposed to happen. So I'm going to say that means further education is needed. So that's my first one. Yes. I will take my blood pressure prior to taking the nitroglycerin. So a lot of people in my class argued about this one because they were like, nah, it's not necessary. But nitroglycerin is a vasodilator, and it can definitely significantly lower your blood pressure. So it's good to have a baseline blood pressure to know that it's safe to take. Now, this is not, what do you call it? This is not saying that you're in an emergency. You're like, oh, my chest is hurting. I'm going to sit down and, what do you call it? I'm like having an emergency, like you're at home, you're out, like, doing something, and you start having chest pain, and you're not like, oh, well, I got to go wait till I take my blood pressure first before I can take my nitroglycerin. But, usually in the hospital, before I give nitroglycerin, I'm checking a blood pressure. It is super dangerous because it can lower your blood pressure significantly. Vasodilators have a severe drop in blood pressure. We'll talk about those more when we get to hypertension meds. They're around the corner. So this answer is actually correct. They should, if they are able to, it's not an emergency situation, they should take their blood pressure prior to taking the nitroglycerin. It can take 10 to 15 minutes for the medication to work. So I think that this one's false. I feel like it works right away. If I'm having like a blockage in my heart and it's like, I'll be with you in 10 to 15 minutes, like that sounds pretty dangerous. So I'm going to say that is false. That's my second one that I'm going to say A and C so far. I can take this while I am exercising to reduce my chest pain. Well, I think you could take it before you start exercising, but you shouldn't take it while you are exercising because you always want to sit down when you take it because you could pass out otherwise. So far A, C, and D. And then it says I should change positions slowly while taking nitroglycerin. So yeah, so definitely, I know that it can lead to that orthostatic hypotension because it is a vasodilator. So I'm going to say that's true. So I'm left with A, C, and D. So you just want to make sure not to make too much of a story around these. So it's really easy in these, like, to read them and like kind of read more into a story, but really we're just trying to see like, we're trying to get you to see, not little petty details, but more like what's safe around this medication. Like we want you to understand, how quick is this going to work? Is this an emergency med or is this a med that's going to take a little bit of time? What assessments and other things need to be done before, during, after. So just start thinking about what makes sense, versus looking too deep in the weeds about some of the little details. Or trying to create a story with some of the answer choices. So let's talk about nitrates. They're short-acting and long-acting. So kind of like there's short-acting insulin and long-acting insulin, or short-acting beta agonists or long-acting beta agonists. But the short-acting, as always, it's for emergencies. It's for a problem right now. We usually give it sublingual, and we have tablets or sprays that can be given. And it should start working very quickly. Common side effects people would complain about are things like headache and flushing, and that relates to the vasodilation that's going on. They also can have a lower blood pressure or might complain of dizziness. But what we're going to be concerned about, or when we're going to maybe want to intervene or step in or do something to help, or what do you call it? Maybe consider like, that the medication's not safe, is, and really when I say that is like, like if I was in the hospital, I was taking care of a patient, I was going to give them nitroglycerin. If their blood pressure is already low, I'm not going to be giving nitroglycerin. It's not safe. But we want to be watching their response to it too, because some people can have a very severe drop in their blood pressure. So while it's expected for it to drop their blood pressure, we're going to be looking for a severe drop, severe hypotension, when it comes to this medication. Teaching wise, we want them to take a dose, and then if after that dose, if they don't feel better after 5 minutes, we're going to tell them to call 911. Now, this is very different than what we used to teach. And so if you see some of my other lectures, you're going to see that I say, there's like the 3-dose thing, and, then you call 911. Now the new textbook says just a one time, try it. If it's not better in 5 minutes and you're at home, call 911. In the hospital, someone asked me this, like in the hospital, is it the same? And no, it's not. In the hospital, we can give multiple doses, but they're being monitored, so it's a little different. Effectively, they just don't want you going through 3 doses in 15-20 minutes, and if it's not better, then that's all that time is muscle. Patients should keep their nitroglycerin on them at all times because it's an emergency med, so you never know when you might need it. We want to tell people to keep pills away from all light and heat sources in order to maintain it so it does not expire. We want to tell the patients to sit down before taking. You always want to sit down before taking, as a means of, because it can definitely cause that orthostasis, that severe drop in blood pressure. And so like let's say I had a patient, I was walking in the hallway that started having chest pain. Usually the first thing I want to do is sit them down. Some people might say, oh no, just stick it right in their mouth. They could literally pass out as a result of it. I told the funny story in class about the time, and I'm not going to tell the full story here since it's it's not my shining moment, but one time I got a little too vasodilated because of some alcohol and other factors, and I ended up like my legs literally just gave out on me, and I like face to the floor, and I was fully with it. I didn't pass out, but it was literally that I got so vasodilated, could not get blood back to my heart, and stuff started pulling, and needless to say, this could definitely happen with someone with nitroglycerin too. So if someone's already, having some issues with perfusion, oxygenation, getting blood back to their heart, and you give them nitroglycerin on top of it, it helps open the coronary arteries, but it can cause a massive vasodilation. And I feel like I did talk about keeping away from light and heat sources, but just in case I didn't, it's just light and heat can cause the medication to not work properly, and then that's why you also want to make sure that they're they have a tingling when they take it. They should feel a tingling, usually under their tongue. It's usually a sign that it's not expired. This also can be used kind of like Sabbaths can be used, where we can take it before strenuous activity. So this is great for patients that, are trying to get back to their life, their activities, but are finding that what do you call it, that they, can't tolerate activities, is they can take this prophylactically before the chest pain even starts, and it kind of opens things up. So they would do this kind of like we talked about before. They'd probably take their blood pressure. What do you call it? If their blood pressure's good, they could take the nitroglycerin, sit for a few minutes, wait, let it take effect, and then change position slowly and get up and get moving. And then additionally, we don't want to take the short-acting or any nitroglycerin with any erectile dysfunction meds. And I explained this on other videos, but effectively, erectile dysfunction meds are the same as or vasodilators too. And so they can cause a lot, like pretty much it'd be taken like a double dose of vasodilators. And when we talk about hypertension meds, we're going to talk about you can take multiple hypertension meds at the same time, but you always want to make sure that there's certain meds that are not appropriate, and two vasodilators at the same time is going to be one of those combinations. Like there's going to be some meds, okay, like some people take 4 different meds that are antihypertensives and they're fine, but two vasodilators, that's too much. It's too much vasodilation, and it causes that severe drop in blood pressure. So we do not want to give two vasodilators. So and all of them end in fill. So you want to definitely avoid anything that starts with that. So, as a whole, summing up the teaching, we can take it before activities, 5 to 10 minutes. Just make sure they sit down first. Make sure it's not expired. It's keeping it away from light and heat sources. You're keeping it on you at all times. You should be experiencing some sort of tingling, and we call it where you took the medicine. It shows that it's effective. And if you're not feeling better, you should call 911 after 5 minutes if you're at home, and don't take it with other things that are vasodilators. There's also long-acting nitroglycerin. This can be given orally, it can be given by topical, ointment, or patch. And this is the topical ointment. So pretty much what your order is, you have this nitro paste, and then you put it on this little piece of paper that comes with it. And the order will be like 1/2 inch of nitro paste or something like that. And so you literally put, however many inches that the doctor wants to give. You put it, like you measure it out here, you just kind of squeeze it on there, and then you put that piece of paper with a piece of tape over it onto the patient, almost like a patch. There also are oral forms, and these all have isosorbide in the front, and then you can always remember they're a nitrate because they have it in the second part of the name, the dinitrate or mononitrate. So these are great for, so we don't have to use our short-acting nitroglycerin so often, because we don't have to be rescued all the time. And so this is not to be used during sudden chest pain. If I was having sudden chest pain, this is not the medication to use. But it's great for patients that have long-term chronic stable angina, and we're trying to reduce the amount of attacks that they're having. Same side effects, same potential complications, but just the things to keep in mind that are a little different is that these are usually kept on for a longer period of time, like patches and the ointment, but they can develop a tolerance. So we usually want an off period. So usually they'll keep it on for maybe part of the day, the 12 hours while they're awake, and then take it off for 10 to 14 hours at night. And so usually we want to use it during the day when they're up moving around, when they can, it can have the best effect. If you're going to be the one to apply this, you want to make sure that you're wearing gloves so that as to not have any sort of injury or serious problem occur. And then you want to make sure to wipe off the paste when you're done so that it's not just staying on the skin and can later be absorbed. So as the nurse, what am I doing for this patient? Sorry, I got to move my face. As the nurse, overall, like I said, time is muscle. We do not want to, just mess around and just hope for the best and hope that something gets better soon when someone's having acute chest pain. We want to seek help immediately, especially if the pain is getting worse or different. And I'm going to talk about some priority actions here before the end of the PowerPoint. Regular pain assessments and perfusion is going to be key for this patient. Again, noticing those subtle cues of what their pain started at, what it is now, and what's changing. Is it the same pain or is it a different pain? And then, checking their oxygen levels, checking their vital signs, checking to see how their organs and rest of their tissues are getting perfused. We want to tell patients that have angina to avoid anything that causes it, or to take nitroglycerin, before they're going to do their activity, as to ideally, patient never gets to the point where they have angina. If we know what triggers us, then we can go in and stay ahead of those triggers. And then also teaching them energy conservation techniques. Even though we have these meds, their bodies are working with these very narrow pipes to their heart, that might be full of plaques. And so even with some treatment, also some lifestyle modifications where they maybe need to learn to take it a little easy, spread things out throughout the day. We want to do other things that are going to decrease the stress on the heart and decrease them from needing to have like having issues where their body's going to have to work that much hard, that supply demand. Definitely smoking cessation, but a vaccination as well. We don't want these people getting sick because their heart just doesn't have the same supply and demand that someone who does not have CAD does. We always want to take care of our other organs, other conditions, low diabetes, high blood pressure, and we've talked about the DASH diet. Sorry, no, we haven't talked about the DASH diet, but we've talked about, we're going to when we talk about hypertension, but heart healthy diet we have talked about. And then remember your A, B, C, D, E, F, which is, and your book has this in it. I took out ones because they also had ones for acute coronary syndrome that didn't apply since we're not covering that. But this is your A, B, C, D, E, F. This is something great for your note card that you can put on, and it really brings down a lot of the basics. So for your A's, you have your antiplatelets, anti-cloggers, anti-anginals, which is your nitrates. B is for blood pressure control. C is for cigarette smoking cessation, managing your cholesterol, and cardiac rehab, and that's going to help with the balancing rest and activity. There's also D for diet, so helping to manage your weight can help. Managing obesity, even a mild weight loss can make a big difference. Managing the diabetes and other chronic things. And then remember, don't forget how much stress can affect your heart health. So depression screening. E is for education. Education is so key. We can give them meds all day long, but if they're not taking them right, or if they're not also changing their lifestyle and other things, it's not going to make a difference. We're not trying to outrun our diseases. So like I can keep upping my cholesterol meds, but if I'm still eating like crap, it's not going to make a difference. Then there's also exercise. Exercise and getting moving is so key. And then, like we mentioned, the flu vaccine, or preventing other things that are going to stress my heart out. So if there was a patient that was in front of me, they're having acute chest pain, my priority actions would be to place the patient upright. In other words, and when I say upright, like I want them sitting up, it's going to help with oxygenation, things like that. But I really like when it says place patient upright, make sure that, in other words, it doesn't mean get them up, but it means, sit them up if they're in bed. And then if they're, out walking in the hallway, I want to sit them down. Apply oxygen, because here's the thing, a lot of times people might wonder, why don't we just give them meds first? Why wouldn't that be priority? But remember, with chronic stable angina especially, it can get better with rest. Why wouldn't I try least invasive first? Why am I going to go stick a pill in their mouth when first things first, let me try just getting them to rest, because they may still need that nitroglycerin, but let's go ahead and take away that extra demand that's coming with them walking and moving around. So sit them down. We want to apply oxygen, get them getting good oxygen in their system, because remember, we could also have a decreased supply or more of a demand. So we want to help with that by applying oxygen per orders. Assessing their vital signs is going to be key to see how they're doing, if they're stable. We're going to attach them to a monitor, maybe get a 12-lead EKG, see what's going on. If it's indicated, administering nitroglycerin, then checking to see if their troponin levels are elevated, doing an assessment of their heart and breath sounds, and then if they need a chest x-ray, we will get that ordered. So you can see it's a lot of doing things to really get to the bottom of the problem and see how severe the damage is. All right, we made it to the end. Here's some more open-ended questions. And again, these are great to do at the end to bring things together. So what assessments, labs, or diagnostics need to be made on a coronary artery disease patient? And what findings need to be reported? So, we talked about assessments, that we're going to be doing a lot of stuff around the lipid levels. We're going to be looking to make sure that there's no further damage, that their heart structure is stable. We're looking at their electricity, their muscle pump, with echoes, EKG, maybe stress tests. We're going to look at if they're diabetic, their hemoglobin A1C. We're going to look how their perfusion is in their body. A lot of times people have CAD, they could have PAD. How's their flow in their body? How are their organs doing? That's a real big overview. What findings need to be reported to the physician, if they had elevated cholesterol or other issues, you might want to report it definitely if there's elevated cardiac enzymes, if there's anything that's abnormal or showing that it's getting worse. Remember, CAD should have no symptoms, so if they start to have symptoms, I'd be concerned. What medications that can be given for coronary artery disease that may react or have adverse side effects when given together. So coronary artery disease, I would be concerned if someone was taking the statin and the fibric acid derivative together. If those are given together, remember they can cause that rhabdomyolysis or that the muscle breakdown, which can lead to kidney failure. I would be worried. Some people, sometimes people are onto antiplatelets. They're on aspirin and clopidogrel, but you do want to be worried if people are taking multiple meds that can make them bleed. So just kind of looking at that, or if people are taking, antiplatelets, but also taking other medications that can make them bleed, like supplements and things like that as well. So that's a few off the top of my head. There's a lot of medication interactions with some of the others, but those are the first few I think of. What assessments need to be made prior to giving medicines for chronic stable angina? So the main medicine for chronic stable angina is going to be the nitroglycerin. So I need to check their blood pressure. I need to do a good pain assessment if they're having pain. Checking to make sure, I'm trying to think if there's anything else. I'd say it's like blood pressure, pain. That would be for nitroglycerin. I want to say that's most of it, but my brain may be fried by now. But that's some of the priority big things. The only other meds we give for angina are going to be things like cholesterol meds. So I'd want to assess maybe liver function. If they're having any muscle pains, look for a rash for a lot of them. And then the antiplatelets, if they're getting antiplatelets, I would just want to look for bleeding. I would want to maybe check their hemoglobin or platelet count, see if they're bleeding or having clotting issues, etc. Client with chronic stable angina is having chest pain. The rest of nitroglycerin, they rest and are given nitroglycerin are still not getting better. What additional tests or diagnostics are needed? And what are your priority actions? So if they're still not getting better, hopefully I already have oxygen applied to them. Hopefully they're already rested. So but hopefully they have oxygen applied. And then we would start getting into getting an EKG, getting cardiac enzymes, probably another dose of nitroglycerin. There's times that the oral doesn't work and we end up having to put them on a drip if it's very severe, things like that. But the main things would be EKG, make sure they're on a cardiac monitor and have oxygen on, get cardiac enzymes, call the doctor and see what further stuff's needing, because this may be moving towards unstable and we may need to do an intervention. Okay, that's that to get started. Oh, I went backwards. That's it. We made it through the first two cardiac disorders. Next up is hypertension.